Good evening to all. Welcome back to CME. Now we shall be resuming with our case presentation. Tonight we will be having a cardiology case presentation. The case presentation shall be chaired by our two esteemed faculty, comprising of Dr. Sudhayakumar Narration sir. A very warm good evening to you, sir.
Thank you.
He currently works as the cardiologist in the Bharat Hospital, Kottayam. His areas of interest include teaching and clinical cardiology. He has served the Medical Education Department of Kerala from 1981 to 2007, mainly as the faculty in the cardiology department. Also, among the esteemed faculty includes our beloved Dr. MGK Pillai, sir. A very warm good evening to you, sir. MGK Pillai, sir, as we all know, is currently works as the HOD in the Department of General Medicine, AIMS Kochi. I cordially invite you all to this case presentation.
Before starting, let me thank the whole team for the real pleasure in joining the institute where I have worked for about 7 years, involved in training of the medicine MBBS students, medicine postgraduates and cardiology postgraduates. But more important, the good relation I have with the faculty there. I'd like to see Pillai sir also after a long time. Anyway, his presence is a great stimulus for me also. We had a very nice time in the academic session in Mumbai. Good evening, sir. Good evening. Good evening, sir. Nice to see you.
Sir.
Nice to see you.
Just now only I was able to unmute, sir. Good evening.
Okay, fine. Good evening, sir.
Sir.
So it's a real pleasure to be with you as a examiner, not as an examiner, as a teacher for this session.
Sir.
And Sudhaya, this is only a teaching session. Don't get upset. No questions, no harassment, no only teaching, no cheating. Okay. You be relaxed.
Okay, sir.
Sir, Pillai sir.
Sir, I think she is also having some fever and other things.
Yeah, I am also having. I am also
positive.
positive.
Yeah,
both of us are positive.
Now I am also in the same group.
Okay, fine. So the COVID team.
No, sir.
Okay. Shreya, are you healthy? Are you okay?
Yes, sir.
You can tolerate our comments?
Yes, sir. Sure,
okay,
sir.
Fine. Shall we start, sir?
Sir, please, sir.
Okay. Shreya, go ahead.
Okay, sir. Thank you. So today I'll be presenting a CVS case. My patient is a 50-year-old female from homemaker from Thrissur who's educated up to class 10. So she came with chief complaints of breathlessness since 10 years and palpitations since 3 years. So patient was apparently normal 10 years ago, following which she started developing breathlessness on exertion, which was insidious in onset and gradually progressive in nature. At first, she noticed that she was breathless while climbing 2 flights of stairs to her house, which she could do so effortlessly before. Over the next 5 years, she had gradual worsening of her symptoms and she found it difficult to even walk to a nearby store because of breathlessness. Since the last 2 years, she feels breathless even while she walks and goes to the washroom. Since the last 1 month, she has breathlessness even at rest. Since the last 1 year, she also noticed to have breathlessness when she around 2 to 3 hours after going to sleep, following which she wakes up from sleep and has to sit up and take fresh air from the window for symptomatic relief. Last such episode for us was around 5 days ago. Since the last 1 month, she also complains of developing breathlessness on lying flat and has to use 2 to 3 pillows while sleeping. At present, patient is breathlessness at rest. She has no associated cough, fever, expectoration, noisy breathing, joint pain, or chest pain. A patient also gives history that since the last 3 years, she has awareness. She's aware of her own heart beating. This was insidious in onset and occurred while she climbed to the 2 flights of stairs to her house, wherein she felt sudden pounding sensations of her heart as if it was racing or running. This was again episodic and relieved with resting after a few minutes. So around 1 year ago, she felt a slight change. She felt as if her heartbeat was very fast, but it was irregular. So she was admitted and evaluated in a nearby hospital, following which she was started on 2 medications, metoprolol and warfarin, since the last 1 year. There's no history of lapse in consciousness, blackouts, falls, jerky movements of limbs, uprolling of eyes. No history of heat intolerance, swelling in front of the neck, weight loss. There's no history of dysphagia, hoarseness of voice, no history of embolic episodes like hemiparesis, chest pain, limb claudications, and hematuria in the past. Since the last 2 weeks, she also gives complaints of swelling of both legs and abdominal distension. Coming to the past history, she had similar symptomatology around 6 years ago, following which she was hospitalized and evaluated in a nearby hospital. There, she underwent cardiac catheterization and the procedure was done as part of treatment. She also gives history of prolonged fever with recurrent joint pains in childhood and was diagnosed with rheumatic fever at 14 years of age, following which she was on intramuscular injections once in 3 weeks till the age of 21 years. Coming to the treatment history, she gives history of receiving intramuscular injections once in 3 weeks from 14 years till 21 years of age. Currently, she is on warfarin 3 mg once a day since 1 year, metoprolol 50 mg twice a day, and furosemide 40 mg once a day. Coming to the menstrual and obstetric history, she attained menopause at 48 years of age. She has 2 children. Both were normal vaginal delivery. Last childbirth was 24 years ago. The first pregnancy was around 28 years ago and it was uneventful. Coming to the second pregnancy, she gives history of hospitalization twice for non-obstetric reasons as a result of breathlessness. Coming to family history, she has no similar history among siblings. There is no family history of diabetes, systemic hypertension, coronary artery disease, or tuberculosis. Coming to personal history, her sleep is disturbed since the last 2 months because of frequent awakening due to breathlessness. Appetite is reduced since the last 1 month. She consumes mixed diet and her bladder and bowel habits are normal.
Okay. I think with this presentation, I'll straight away give you a pass because it has been beautifully presented.
Thank you, sir.
Despite your COVID situation, your presentation has been very good. Okay. So presentation of the history, I think you get A+. Okay.
Okay.
Fine.
Thank you. Can I summarize
Now, yeah.
So we have a 50-year-old female with a background history of rheumatic fever who's come with chronic progressive symptoms of dyspnea on exertion, palpitations with recent onset of paroxysmal nocturnal dyspnea and orthopnea, and history of irregular fast heartbeat, probable AF, but further details are not known. But considering the treatment history, it could be AF. And since the last 2 weeks, she's giving symptoms like swelling of legs and abdominal distension. So all these, I think, are pointing out towards pulmonary capillary congestion and elevated left atrial pressure with recent onset of right heart failure. So considering a background of rheumatic heart fever and this elevated LA pressure, I would like to think of a diagnosis of mitral valvular disease, either isolated, either mitral in the form of mitral stenosis predominantly, or MS with some other valvular heart disease, sir.
So who is training
Currently
you to this level?
functional class 4.
So what is your final diagnosis based on the history? Complete perfect 10.
Okay.
Perfect 10 in gymnastic, we say perfect 10 diagnosis.
Okay. Coming to the physiology, I would like to.
No. I have asked you what is the final diagnosis. You have done so far A+. Okay. I appreciate the faculty who is training you to the real correct cardiology level of approach. So credit to the student as well as the team.
Thank you,
okay,
sir.
fine.
Okay.
Now the question is, this is the final question and your outcome is based on this. What is your final diagnosis based on the history? I want a perfect 10 gymnastics, the presentation of the diagnosis.
Acquired valvular heart disease of rheumatic etiology, probable mitral stenosis with or without underlying, like at this point I cannot exclude an
that
aortic
cannot be diagnosis. Now you are losing the track. I asked you how you write the diagnosis. You cannot say probably excluding all those things. You have done extremely well. Now it should be in the same format. I want the diagnosis which you are writing.
Okay. Acquired valvular heart disease of rheumatic etiology, mitral stenosis with history of AF, and currently in
In the diagnosis there is nothing like with history of AF, nothing like that.
With AF and congestive cardiac
failure. Okay, not enough.
And currently in functional class 4, sir.
Okay, fine. Instead of saying valvular heart disease, probably of rheumatic etiology. That is what you said. So chronic rheumatic valvular heart disease.
Okay.
There is no any explanation needed. Chronic, you have no doubt about that. Chronic rheumatic valvular heart disease. Okay.
Okay, sir.
Then which valve is involved?
Mitral valve, sir.
Okay. Is it stenosis or regurgitation or combination?
Predominant lesion I feel is stenosis, sir, but a combination of
Okay.
lesion being more common,
Yes,
we
yes.
cannot rule out here.
Yes. So rheumatic, chronic rheumatic valvular heart disease, mitral valve disease, mixed mitral valve disease, mitral stenosis with mitral regurgitation. Then what else? Physiology you have to bring in, which has produced physiologically
Pulmonary capillary congestion, sir, with
pulmonary
elevated
venous, pulmonary venous hypertension, which has progressed. Why did she go to right heart failure?
like from pulmonary venous hypertension, it has progressed to pulmonary capillary congestion and hypertension, and there has been some
Pulmonary
vascular
arterial
remodel.
hypertension. Pulmonary, you have to be a little slow in examination also. Okay.
Okay, sir.
Pulmonary venous hypertension progressing to pulmonary arterial hypertension, leading to congestive heart failure.
Okay.
Okay.
Okay, sir.
That is a sequence.
Okay.
Mitral valve disease, probably mixed lesion because there is a commonest, but you can say dominant is, what is dominant?
Mitral stenosis.
Stenosis. Pulmonary venous hypertension, pulmonary arterial hypertension, congestive heart failure. Don't use AF, atrial fibrillation,
Fine.
congestive heart failure, NYHA 4.
4.
Okay. But
Okay,
you missed one thing in this diagnosis. What is that? Going through the history, about 6 years back,
She has underwent a procedure.
what procedure? And you said that what was the cardiac agitation followed by
A procedure, like
what?
it might have been probably it might have been a severe mitral stenosis at that time, and they would have done a commissurotomy at that time. Probably.
What is the difference then? Because you said probably. That means you know something more.
No, sir.
Do you know anything else?
No, sir.
So things are very clear now.
Yeah, sir.
Chronic rheumatic valvular heart disease, mitral valve disease, mitral stenosis severe, status post percutaneous transmitral commissurotomy 6 years back. Now what is the problem? So she had undergone mitral commissurotomy. So now it is likely to be following a mitral commissurotomy. If the patient is having symptoms, the most likely problem is, why do they develop symptom after that?
Restenosis is
One, inadequate surgery or procedure. Second, problems created by the procedure. Third is long-term sequelae of the procedure or the disease, that is restenosis, or development of other lesion which is progressing, associated aortic valve disease progressing, or she is now, how old is she?
She's 50 years, sir.
50 years, whether she is developing some other disease as age advances. So
Okay.
that is the way you have to look into. Okay. So that is
Okay.
a diagnosis format. We know it is chronic rheumatic valvular heart disease. It is severe mitral stenosis. And from the history, your conclusion is it is percutaneous transmitral commissurotomy 6 years back. Okay.
Yes.
Then she has the problem, which is likely. Is it inadequate surgery or splitting? Or is it a problem related to the procedure like inducing mitral regurgitation or a restenosis? That are the first two things, which is more likely.
Restenosis is more likely considering
Yes.
this history, sir.
Why? Why not inadequate splitting? Why not a problem related to the procedure?
Because this procedure was done 6 years ago, and after that she has had some transient relief for symptoms for some
Not
time.
transient. For how long she had relief of
Actually, for
symptoms?
last 6 years, like for last 5 years almost, she has been able to carry on.
Don't say transient. She has good symptomatic relief for 5 years. That means the split has been adequate. If we had induced some problem, she would have landed up in pulmonary edema at that time. Okay. So what do you, when will you say it is a sustained improvement? She says, you say that the patient has improved. Patient, say patient was getting PND, orthopnea, all those things, and following the procedure from mitral valve area of 0.8 square centimeter, it has been opened to 1.2 centimeter square PND disappears. But later this patient will do. So when will you say the symptom relief is satisfactory relief and sustained relief? It should improve by 2 classes. From class 4, she should come to at least class 2. And it should be sustained for some time, ideally more than 6 months to 1 year. So she had a good symptomatic improvement, indicating that the commissurectomy was adequate, with good outcome, and did not have any problems initially. So there was no problems related to the procedure, that is MR. Now she has developed symptom, most likely restenosis.
Okay.
Or it is possible that she might have a aortic valve disease, which might have been mild or moderate at that time, which might have progressed. But orthopnea, PND, all those things, it is much more common with mitral valve disease, because mitral valve is very close to the left atrium. So left atrial dynamics are influenced mainly by mitral valve. Whereas if it is aortic valve, it should affect hemodynamically the aorta or the left ventricle. Stenosis producing low output with symptoms related to that. Regurgitation producing volume more to the left ventricle, producing LV volume overload, palpitation of volume overload, and LV failure. And aortic valve disease, when they develop LV failure, they will be in a very bad shape.
Rapid deterioration.
It will be relatively an advanced stage. Okay, Pillai sir. Sir, you may be taking rest. Then we'll come back. I have gone this thing. Now you have presented very well.
Sir. Hello, sir.
Sir, your contribution?
No, sir. I think you are actually covering everything.
Okay.
Yes, sir.
Okay. Shall I proceed?
Yes, sir. Sure.
Sir, you also have to contribute in between. Now you have come
And
fairly well.
We have divided, and he actually was telling on the wrong short case, each case discussion by each person. That was the.
Okay. So this is how much time, sir?
1 hour or more, sir. You take 1 hour plus.
Okay,
2
fine.
hours are there.
Okay, fine.
And it's only a short respiratory.
Okay. Sir, you should tell me at least 10 minutes before, prior, then I have to stop.
Yes, sir. Subhash is there as a controller.
Okay. Tell him that he has to warn me 10 minutes prior to.
Yeah.
Yes, sir. No problem. Sure. No problem, sir. No problem, sir.
No, the problem with that is I am taking class up to 12 midnight. That is a problem.
I know, sir. Everybody is eager to hear from you.
Now, your presentation is good. Okay, 50-year-old female. Dyspnea you have presented very well. That is the progression of the symptom with description of each class you have said. Okay, that's fine. Then next thing is palpitation is one. First you have to say it is on exertion. It is not that fast but regular, relieved by rest. The second is fast, irregular. Was it only on exertion or at rest also?
Okay.
Was it paroxysmal palpitation or not? In palpitation, when you analyze palpitation, you need not start like saying that unpleasant awareness, because that may not be needed. You can say palpitation.
Okay.
What is it? Is it on exertion only, or exertion and continuous at rest, exaggerated with exercise, or paroxysmal palpitation, episodic palpitation unrelated to any exertion? These are things, because our aim is whether the palpitation, what is the mechanism of palpitation? Why do they develop palpitation? Which are the things which contribute to the symptom of palpitation?
Increase in either the rate of increase in either heart rate, increase in either the force of contraction.
Very good.
Or high volume.
Force of contraction.
Or increase change in the rhythm.
Fine, excellent. So rate, regularity, force of contraction. So you have to identify that. Okay, that is not easy, but you can try. So you have to look in that. So for the last 1 year, she is getting fast, irregular palpitation. Was it on exertion, or was it present on at rest, exaggerated by exertion? What was it?
Paroxysmal, sir, in this case.
It was episodic irregular palpitation.
Yeah.
Okay, that is very unusual in established mitral valve disease. In established mitral valve disease, initially they can have episodic palpitation, but over a short time they go in for persistent and permanent AF. Okay, so you have to check. Now, we have seen so many patients with valvular heart disease and chronic atrial fibrillation. where they have irregularity at rest, but exaggerated during exercise. So you get this patient, she has palpitation, she has permanent AF. There is no doubt about that. Okay. So why she should get exertional palpitation then? She is having AF at rest.
Yes.
Why she is becoming symptomatic on exertion?
The
So,
tachycardia.
what tachycardia? Or rather than tachycardia, you say the rate.
Rate, increase in rate.
Which rate? Atrial rate or ventricular rate? Obviously, you know that, but it's not a complicated question. Ventricular rate. Be very specific. You say that the ventricular rate increases. Okay. Then you get more marks.
Okay.
Ventricular rate. Why should the ventricular rate increase?
Compensatory, like it will try to increase the cardiac output at the time of exertion.
No. We are not talking about cardiac output. We are talking only about palpitation. AF is there. The next thing is we say that the ventricular rate is increasing.
Yes.
Why the ventricular rate is increasing with exercise? You know the answer. Normally the sinus rate increases.
Yes, sir.
Here the atrial rate is 300, 400 per minute. So why the ventricular rate increases? What determines the ventricular rate in atrial fibrillation? You know the answer.
AV conduction.
Yeah, that's right. AV conduction. So what happened to the AV conduction with exercise?
Increased firing will be there, you know, across the increased firing will be there across the AV.
Not increased firing. Firing means automaticity.
Okay.
It is an enhanced AV conduction.
Conduction.
Mediated by? You know the answer. With exercise, why should the heart rate go up? What mediates that?
Catecholamine surge at the time of.
So with exercise, the catecholamines, which enhances the AV conduction. So the atrial rate is 300 to 400 per minute. The AV node cannot conduct fast. And in chronic cases, AV node becomes fatigued, just like our performance now. You become fatigued. So the AV node becomes fatigued. Along with that, you give beta blocker, digoxin, all those things. So AV node conduction slows down so that the ventricular rate gradually comes down over time. But when the catecholamine comes, AV node conduction can improve. So that is why they develop exertional palpitation.
Okay.
So still it is atrial fibrillation, it need not be paroxysmal.
Okay.
Because statistically, chronic mitral valve disease, once they develop atrial fibrillation, they are likely to be persistent or permanent. But if the ventricular rate is controlled, they may not have much symptom at rest. But when they exercise, the ventricular rate will increase because of the enhancement of the AV conduction, plus increase in the force of contraction of the ventricle also. Okay. So that can be explained. So along with that, whenever you discuss palpitation, you have to see what is the rate, what is the regularity, associated symptoms. What is the associated symptom which she has? Along with the symptom of palpitation, she is getting breathlessness.
Yes.
Okay. Then you said on warfarin. Why did you say warfarin? She is educated. Am I right?
Yes, sir.
So she can say that these were the drugs she has taken.
Yes, sir.
But what will be the better way of presentation? She was put on, she was on. Was it acetrom, acinocumarin? You know about acetrom also? You heard about that?
Yes, sir. Yes.
Was it warfarin or acetrom? I'm not sure. Then what will you say? In anticoagulation, how will you approach pharmacologically? Whether it is...
The INR was checked.
No, that is checked. She is on INR, all those things. Instead of saying acetrom or warfarin, which will be the better pharmacological terminology you can use? Say the oral anticoagulants can be classified basically as two.
Vitamin K.
Vitamin K antagonist versus other non-vitamin K antagonist. It could be direct acting, all those things. So you could say, sir, she was put on vitamin K antagonist. You'll score 1 mark more rather than saying warfarin. It doesn't matter whether it is warfarin or acetron. We want to know whether she was put on vitamin K antagonist.
Okay.
So she was put on vitamin K antagonist, which was being monitored by regular INR checking. Fine. Okay.
Okay, sir.
Then that was the thing. Then she underwent cardiac catheterization. She underwent cardiac catheterization. What
Yes,
did you
sir.
say about that 6 years ago?
So she had the
Go back
same.
to the slide.
Yes.
No. History of no prior. That is 6 years ago. In the presenting complaints, you have said. Previous slide. Yeah. Patient is since 1 month. Okay. Okay, just tell. 6 years back, she underwent
This one, sir.
similar symptom, but there is some problem there. She was symptom charted 10 years back.
Yes, sir.
Then how can this be past history?
Like
No,
like how she's having class 4 dyspnea now. That time also she has.
We have to modify a little bit.
Okay.
Go back, first slide. Back. Okay, you started this is the area where you have said breathlessness 10 years.
Yes,
That
sir.
is your presenting complaints.
Yes, sir.
So you have to start from that level.
Okay.
Okay, next slide. Patient was apparently normal 10 years ago. Then she progressed like that. Okay. At first she was breathless. Progressively over the next 5 years, she found it to a nearby hospital. Then in between she underwent the procedure. So that should come there. Because that is related to this.
Okay, fine.
Now,
Okay,
it has been quite unrelated, I might have excuse, but that's an important component of the present history because it is closely connected. So that is not past history. So they started from 10 years ago. She progressed to class 3 by 5 years back, and she was found to be difficult because she was in function class 3. At that time, you can say that. At first, she noticed that she was breathless by climbing 2 flights of stairs to her house, which she could do effectively before. That means she was in class 2. Her symptom gradually progressed, and over the next 5 years, she found it difficult to walk to even nearby shop because of breathlessness. So she was in class 3. She was evaluated in detail in a tertiary center. She underwent cardiac catheterization. That's a word you used?
Yes, sir.
Yes. She underwent invasive evaluation, cardiac catheterization. And along with that, she underwent a therapeutic procedure also. Okay, that's the way. Then what happened? Then the symptoms improved. Then only that sequence comes.
Okay.
Then the symptoms improved. She came to class 1 or class 2. She started doing normal activities. For the last 2 years, she is getting breathlessness. Oh, there the problem comes. Now you have to modify. So, I mean, right, 10 years history, initially class 2, progressed to class 3, 6 years ago, cath with PTMC. Then the symptoms improved.
Yes, sir.
Symptoms improved to which class? For how long she was in class 1 or 2? Then she restarted developing symptoms because that period is important. To diagnose restenosis, there should be a sufficient period of good symptomatic improvement. Then you can straight away say it is restenosis. Then you have to say over the last year, she started again breathlessness. No, here it was a continuity. So that should be modified. Okay.
Okay, sir.
Because that is related to this. That's not past history. Okay. Is it clear?
Yes, sir.
Now, next slide. Okay. So that should have come there. Then it's okay. Fine. Next slide. Now, previous one, edema, Lex, when she started developing previous one, or no, previous. Now that complaints of swelling, this should come before this. Well, this is positive.
Okay, sir.
This is important. Whereas the other are negative things, but this is extremely important because that physiology is continuing. So previous slide. So after finishing previous slide, no swelling in front of neck. Patient is awareness of this is palpitation. So after dyspnea, you have come to palpitation.
Yes, sir.
Okay. Now after that, you should come to lapse in. Okay, before that palpitation. So you have to finish the history of dyspnea. Then palpitation, she is getting as if heart rate was fast. Then lack of consciousness blackout, that is along with the palpitation. No history of syncope or pre-syncope. That is fine. Then no stress swelling in the front of neck, heat intolerance, weight loss should come later.
Okay, sir.
Before that, you should take over the last 2 weeks. She is having edema of feet and
Abdominal distension.
abdominal distension. But along with that, you have to add something more. That is about oliguria, whether
Okay.
GI symptoms like loss of appetite, because there will be mucous, there is planktonic edema. When there is ascites, the portal pressure is high. That produces plank. So there can be gastrointestinal symptoms.
Okay.
Loss of appetite, nausea, vomiting, so many things can happen. Okay. Whether that was associated with withdrawal of any drugs or not. You should know why she worsened, why she went in for heart failure. So she was developing progressive symptom of breathlessness, and why she developed this symptom. Was she on regular medication? Then whether there was any withdrawal of drug, whether she took excess fluids, whether she had fever or cough, that. Then you have to tell all the negative things. The previous slide, I don't know the previous slide. I don't know how to present. No stiff swelling in front of the neck. I may say no stiff thyroid swelling, heat intolerance like that. Okay, that you can get opinion from your teacher. Okay, because there is some difference in the format for MBBS, MD, and super specialty.
Okay.
So at your level, certain conclusions can be drawn if I am the examiner. No history of thyroid swelling, heat intolerance, or weight loss. Next slide. All those things, no. Okay. Very important. No history of dysphagia, no history of hoarseness of voice, no history of hemoptysis is very important. So what you have to look is cardiopulmonary. So left heart, pulmonary vasculature, pulmonary, and right heart. That is the way you have to look into. So in the pulmonary, we have looked for hoarseness of voice, dysphagia related to the thorax. Hemoptysis you have to tell.
Okay, sir.
Okay. So no history of hemoptysis, no history. That you can tell along with PND also.
Okay.
When you are telling that during night she wakes up, all those things, and PND, no history of hemoptysis. So that modifications you can make, so that you will be getting bonus mark also. No history of such embolic episodes. Okay.
Okay.
Now coming back, what are the questions you are likely to face? That is the thing which you should know. Which are the questions you are likely to face? I always teach the students, this monotonous presentation you will be hearing every time. Okay. But you should note down the questions asked. If the questions are familiar, then answering is easy. And for each question, there will be answers in the textbooks. You need not roam around. You need not blame the teacher. So you should anticipate the questions at each point. So we take from the first slide. What are the questions that are likely to be asked? Take
Differential diagnosis.
First slide. Okay, next. Okay, next, first slide itself. Any questions can be asked? First slide. Before that, previous one. So 50-year-old female coming with heart disease. What are the possibilities you consider? 50-year-old female coming with heart disease. Which are the possibilities you consider? Today, we had a discussion for cardiology postgraduate.
Yes.
It was an exam. One of the examiner asked, it was a 65-year-old male. Which is the heart disease you are anticipating? 50-year-old female, heart diseases. Which are the heart diseases we'll consider? Let us say she has heart disease. So statistics.
Coronary artery disease.
Very 50-year-old female. Okay, fine, but not very common. Okay.
Then.
So you have to say, sir, a 50-year-old post-menopausal woman with coronary risk factors. Okay, coronary disease to be considered. But which is more common in 50-year-old female? Which are the heart diseases, you know? Congenital heart disease, acquired heart disease. Which is more likely?
Acquired is more likely.
Acquired is more likely. Acquired is hypertensive heart disease, valvular heart disease, ischemic heart disease, myocardial disease, pericardial disease. That is all.
Yes.
Which is more common? I put it. Hypertensive heart disease, valvular heart disease, ischemic heart disease.
Hypertensive heart disease is common.
Hypertensive heart disease is more common.
Yes.
Which is uncommon, which you have not seen. Hypertensive heart disease is pericardial disease. Then comes ischemic heart disease, valvular heart disease, and cardiomyopathies, which you have seen more commonly.
Ischemic heart disease is common.
Valvular heart disease maybe, but
Okay.
valvular disease can extend. Which is the commonest valvular heart disease? Not for
Mitral.
examination, but if you take, no, rheumatic heart disease is extremely uncommon in Kerala. You know that? Rheumatic heart disease is extremely uncommon. Rheumatic fever is extremely rare. Okay. For
Okay.
examination, that is a commonest, but that's not in your practice.
Okay.
In practice, hypertension, ischemic heart disease, okay, but valvular heart disease. Suppose you get 100 people with valvular heart disease at the age of something like 20 to 30 years, which is the commonest. It is mitral collapse. Mitral collapse. Mitral collapse is the commonest valvular disease. The commonest valvular lesion is mitral regurgitation, non-rheumatic, and in the older, atherosclerotic or degenerative or calcific aortic stenosis. Okay, so valvular heart disease, sir, mitral valve disease, especially non-rheumatic, mitral collapse is very common. Okay, it could be rheumatic also. Ischemic heart disease, or if she has postmenopausal woman with risk factors. So that is the way we look into. That is the importance of the age. That's the problem which senior teachers like us will be looking into. We look at that group and assess which is the likely heart disease. Now you have got A plus. Can you have a congenital heart disease at this age group? 50-year-old female with a congenital heart disease. What is it likely? Cyanotic or acyanotic?
Atrial septal defects can become.
What was the question? Cyanotic or acyanotic? Cyanotic will not survive without symptoms up to that. So acyanotic. Acyanotic, we have 6 conditions: 3 shunts, 3 obstructions. ASD, VSD, PDA. Aortic stenosis, pulmonary stenosis, coarctation. 6 acyanotic. 1 cyanotic is tetralogy of Fallot. You need learn only this 7 because 90% will come under this. VSD and PDA, by this age group, they will develop Eisenmenger. ASD, they remain asymptomatic, present with heart failure in the 4th and 5th decade. It is more common in females.
Yes.
Okay. So if I get a 50-year-old female who has presented with cardiac failure symptoms or cardiac disease, hypertension, but seldom they go in for congestive heart failure. It is treated. Then valvular heart disease, anything can happen. Mitral regurgitation is more common, or it could be mitral valve disease of any etiology. Then coming high-risk cases, ischemic heart disease. But ischemic heart disease presenting with heart failure of 10 years duration is very unlikely. If it is a congenital heart disease, it has to be acyanotic congenital heart disease, and the one with presence at this age group remaining asymptomatic for long is ASD. So that is the importance of that age and heart disease. Then homemaker doesn't have much significance. Next slide. Okay, next slide. Okay, here I have done it very well, but what are the questions that can be asked in this? Okay, what is the functional class? They will ask you N by HA functional class. Can you give what is, if I am asked to write N by HA class, short note, what will you write?
In which a class 1 is no limitation of routine physical activity.
There should be an introduction.
Okay.
It is only for heart patients.
Cardiac causes of dyspnea are graded in 4 based on
not dyspnea. 4 symptoms. What are the 4 symptoms?
Dyspnea, angina, palpitations, and fatigue.
Fatigue. So that is the introduction. It is only for cardiac patients, and 4 symptoms can be considered. Then 1, 2, 3, 4. Okay. What is class 4?
Class 4 is symptom even at rest, sir.
No. That you can say maybe symptomatic at rest, but that is not the definition. In the classification, there are 2 things. What is the activity which is producing the symptom, and what is the limitation of the activity? Class 1 means no symptoms on routine work, hence no limitation of the activity. Class 2 is symptoms on routine work, slight limitation of activity. Class 3 is symptoms on less than routine activity, marked limitation of activity. Class 4 is the patient cannot perform any activity without symptom. Maybe symptomatic at rest. That's it. Symptoms at rest is fine, but the definition is the patient is disabled, cannot perform any activity without symptom. She may be very comfortable on sitting, nothing, but she starts combing the hair, she gets symptoms. She may be symptomatic at rest. The next question is, what do you think about orthopnea and PND? In which class does it come? This is a question which is asked, even to cardiology postgraduates. Some examiners disagree with the answer. Sir, paroxysmal nocturnal dyspnea and orthopnea are not included in this NYHA. Why? NYHA is a functional activity classification.
Okay.
The other two things, the mechanisms are entirely different. It is not related to physical activity. You may see a patient with mitral stenosis doing normal household activities, getting episodic paroxysmal nocturnal dyspnea, because the mechanisms are entirely different. That is what we ask here. Next slide. Okay. You are jumping. Oh, okay. That's it. There they will ask you about PND classical description. Okay.
Okay, sir.
Okay. A few hours after which she wakes up from sleep and has to sit up, take fresh air from the window. Such last such episode about what is the duration of the symptom. That is not enough. They will ask you typical PND. Goes to bed without symptom. About 1 to 2 hours into sleep, become breathless, wakes up, sits with legs hanging down, or may even go to the windows, gasps for breath, and the whole symptom subsides within 30 minutes and has a comfortable sleep after that. It doesn't recur in the same night. Associated with sweating and cough with expectoration, bringing out pink frothy sputum. These things should be there.
Okay.
Then what is the next question related to that? What is the mechanism? What is the mechanism?
Three mechanisms, like one during supine position.
Just wait. There is one question: can PND occur during daytime? Obviously not, because it is paroxysmal nocturnal dyspnea. But equivalent can occur in the daytime. During sleep also they can develop. But PND means paroxysmal nocturnal dyspnea. Somebody has put in the chat box. Paroxysmal nocturnal dyspnea means it is nocturnal. But the same phenomenon can occur in daytime also. When the patient sleeps, the same phenomenon can occur, but less likely, because when we come to the mechanisms. Okay, mechanisms.
First one is the shift of fluid from extravascular to intravascular compartment, which is going to increase the venous return. Second thing is in sleep.
Slow. A shift of the fluid, edema fluid, from the extracellular to the intravascular compartment, increasing the central blood volume.
Yes.
Okay, increasing the central blood volume, which increases the left atrial, pulmonary venous, pulmonary capillary volume and pressure. Very good. Second,
like the sympathetic activity might be decreased during sleep.
Okay.
Due to which the left ventricular contraction might be impaired, sir.
Function may get impaired. Fine. But then what happens in mitral stenosis? If the sympathetic activity is less, will it be beneficial or not? If the sympathetic activity is less, the venous tone will come down. Venous pooling will happen. What will happen to the heart rate? What will happen to the heart rate?
Reduce, sir.
Is it beneficial for mitral stenosis or not? We'll come to that.
Okay.
Heart rate is very important. Mitral stenosis, your first aim is bring down the heart rate, which we'll discuss later. Okay, that is second, agreed. Fine.
Okay. third is catecholamine surge, a sudden surge of
That's fine.
catecholamines might be there.
Fluctuations in the sympathetic tone will be a better answer. Okay, then third. Okay. Third, hormones.
Hormones.
Which hormone? Which is the hormone which maintains the fluid balance? Okay. Antidiuretic hormone.
And IDH.
And antidiuretic hormone release is more during daytime or during night? You are not going to the toilet in the night, bathroom in the night.
Daytime.
So it should be more in the night. So antidiuretic hormone is less. So it is released. So no diuresis. So fluid is retained. That is why I said the mechanism in daytime nocturnal dyspnea equivalent. This hormone change is not there, but other changes may be there. Okay, these are the mechanisms you have to say, plus something more. That is the diaphragm going up, interfering with the lung expansion. Then supine position, venous return is more. But these are the three important mechanisms. Two questions I heard is EMF common in Kerala. EMF was very prevalent in Kerala, but it is now less. Second chat was in microstenosis, which heart fails first? We don't talk about failure in that. In microstenosis, left heart failure, because it's a left heart disease. Mitral valve is a left heart lesion, so it is a left heart. Right heart failure is a consequence, as our student said. Microstenosis, left atrial pressuritis, pulmonary venous pressuritis, pulmonary artery pressuritis, right ventricle fails, goes in for heart failure. Okay. So that is a question. Now, what is the mechanism in orthopnea? What is orthopnea?
Breathlessness on supine position, sir.
No. Dyspnea on lying down and relieved by sitting up. Relieved by, that is needed. Orthopnea means dyspnea on lying down and relieved on sitting up. Where the mechanism is on lying down, the venous return increases. Diaphragm goes up. Chest expansion is less. It gets up so that the venous return comes down. Okay. Next slide. Next slide. Okay, fine. I think this is the history discussion which I had. Next. Okay, go ahead. Okay, go ahead. Okay, now comes history of no, the previous one. Okay, second pregnancy, previous one, where you are going to land up in problem. That is second pregnancy, admitted twice due to breathlessness. That was 24 years ago.
Yes.
Okay, your present symptom is only of 10 years duration. She had rheumatic fever according to you. Okay, now was she evaluated during second pregnancy? Was she diagnosed of heart disease? What was the reason for admission? Okay, that you should have asked.
Okay.
Admitted twice during second pregnancy due to breathlessness. Which period she was admitted? Because pregnancy and heart disease is a very, very difficult area. So heart disease, whether the breathlessness was due to cardiac problem or something else. Was she evaluated 24 years ago? Means there was a good cardiac evaluation in Kerala. There was no problem at all. It was a hospital delivery.
Yes.
So was she evaluated? Was she diagnosed of heart disease? What was the reason for that breathlessness? At what period of gestation she became breathless? What was the mode of delivery? All those things should go into the details.
Okay.
Because if she was diagnosed of valvular heart disease, that means the rate of progression of the disease is slow. First 24 years she has diagnosed breathlessness, but then she remained minimally symptomatic or asymptomatic for a quite long time, another 16 years or 14 years she was asymptomatic. So that is also important. That you should have expanded a little more. Next slide. Now that injections. Okay, what is the question that will be asked here? Yes, just a prolonged fever with recurrent joint pains in childhood. She was diagnosed with rheumatic fever at Alile. Now, with the history, is it enough? Is this history suggestive of rheumatic fever? You will get enough questions on rheumatic fever and no questions on PTMC or too much on mitral stenosis. Rheumatic, was it rheumatic fever? Yes, no.
Yes,
Is
sir.
this history typical of rheumatic fever?
Age is like towards
Age is, no, be relaxed.
like
If you
usually it
answer,
starts
if
at a
you
younger
answer,
age.
if you answer 10% of my questions, you are through. Okay, because your presentation was very good, so already you have got pass. Okay.
Okay.
Is this history typical of rheumatic fever? Yes or no?
No, sir, because initially she is telling symptoms only till from 14 years of age.
14
But
years? No, no. At 14 years of age, what is the age for rheumatic fever?
between 5 to 15 years, sir.
So that is okay. 14 years. At 14 years age. Okay. Is prolonged fever a feature of rheumatic fever?
No, sir.
Rheumatic fever doesn't have prolonged fever. Then recurrent joint pains. It is different from an episode with fleeting joint pains. Second, only joint pains. So you can say that rather than saying history of prolonged fever, you can say details she can't recollect.
Okay.
Can you recollect? Did you have fever at the age of 10 years? No. Did you have headache at any time?
Can't recollect.
Okay. If I ask you where was the headache, was it left side or right side? What was the severity? What was the duration? You can't. She is now 50 years and at the age of 14 years, so you have to say at the age of 14 years, she had fever and joint symptom. Details she could not recollect. However, she was diagnosed with rheumatic fever and was put on penicillin prophylaxis for up to the age of 21 years. That is the way you have to present. Next slide. Okay, what is the question that will be asked? Important question and 5 marks will be put for that. What will be the question asked? Because in the examination, you will give us questions. We don't come prepared with questions. You will put something, we will ask questions related to that. So what is the question that will be asked to assess your knowledge?
Duration of penicillin prophylaxis, sir.
Okay, they will ask questions on penicillin prophylaxis. Okay, tell me. So when you get that, these are the questions I'm likely to face. Talk about rheumatic fever prophylaxis.
So it can be either primary, that is treatment of streptococcal sore throat, or it can be secondary.
No, no, what is
prevention.
the question? What is the question?
Rheumatic fever prophylaxis.
Prophylaxis. Already the
Okay.
patient had developed rheumatic. So you are talking about primary prophylaxis and secondary prophylaxis.
Okay.
Okay, fine.
Here, secondary prophylaxis, it depends on whether the patient is having evidence of rheumatic heart disease or rheumatic carditis or not. If there is no rheumatic carditis, prophylaxis is for 5 years or till 21 years of age, whichever is longer. If the patient is having carditis without valvular lesion, valvular heart disease, it is either for 10 years or till 21 years of age, whichever is longer. If there is a carditis with valvular heart disease, it is for 10 years or till 40 years of age, whichever is longer, sir.
Which recommendation you are talking? Okay, there are so many recommendations. Okay, you don't know that. We don't expect you to answer that also. You have ACC-AHA recommendation, WHO recommendation, Indian recommendation. Which will you prefer? Say very, not a practical question. Which will you prefer?
ACC.
ACC. This is the problem. You have the Indian recommendation. You have the Indian recommendation. Why do you want to follow the ACC recommendation for the Indian population? If there was no Indian recommendation, fine. Then you have ACC, WHO. Which will you prefer? Which will you prefer? As a neutral person.
WHO.
WHO. Okay, that's
Okay,
the
sir.
point. And WHO and Indian recommendations are the same. And I want Indian recommendation. That's a point. So you should know the Indian recommendation, which came quite early. Indian recommendation is slightly different. It is there is no carditis up to the age of 18 years or up 5 years, minimum 5 years, which is longer. With carditis, only mild residual heart disease up to the age of 25 years or minimum 10 years. And established heart disease is same. That is up to the age of 40 years or maybe even longer. So that is the importance. The other is ACC-AHA, but we follow, if there are recommendations, pediatrics, we should follow always the Indian Pediatrics Association recommendation. Okay, because rheumatic fever is much more common here.
Okay.
Okay, so I don't know what is your teachers this thing. If multiple recommendations are there, Indian and WHO are the same. You can keep the other thing also. Indian is no carditis, 18 years age or 5 years duration, which is long. Carditis, but no major heart disease in the follow-up, 25 years age or 10 years duration. Severe established heart disease, 40 years or even longer. Okay.
Okay.
Fine. So we have finished the history. We will go to the. So from the history, you have made it very clear that this patient's symptoms suggest pulmonary venous hypertension.
Yes.
Pulmonary venous pressure reflects left atrial pressure. So the left atrial hypertension. And the left atrial hypertension, pulmonary venous hypertension, pulmonary capillary hypertension, pulmonary arterial pressure has to go up to maintain the forward flow. And when it progressively rises, the patient has gone in for right heart failure. That is a physiology. Patient had irregular palpitations suggestive of atrial fibrillation. The patient had rheumatic fever, so obviously mitral valve disease. 6 years back, the patient had undergone intervention, that is commissurotomy, balloon commissurotomy.
Okay.
He remained symptom-free for quite long, indicating good surgical relief or commissurotomy relief.
Okay.
Now she has developed symptoms again, most likely restenosis, or she might have developed other valvular lesion. Aortic valve disease might have progressed, but statistically, it is the mitral valve disease has progressed. It could be that the mitral stenosis has increased, or she might have had mitral stenosis with regurgitation. Regurgitation also has increased.
Okay.
Okay, any doubts? Now we had 8 chats. We will take that. I think we have addressed some. Okay, mechanism of PND with this. Which side of heart fails first in mitral stenosis we discussed. Can MS present with embolic manifestation without this? Definitely mitral stenosis, they can develop embolism in sinus rhythm, but more common with atrial fibrillation, which can be episodic, but without dyspnea, they can. Today we had a case where the patient had. Then here rheumatic valvular is more likely because she was younger at the onset of the disease. Okay, but she has history of rheumatic fever. She had undergone a procedure, and common valvular heart disease is a common cause for heart disease at this age group. Characteristics of rheumatic sore throat, nothing special. I think we have addressed. Is tropical endofibrosis common in Kerala? Now it is uncommon, but EMF commonest is tropical areas. It is described from southern India, Tamil Nadu, Kerala, Karnataka, Andhra, coastal areas. Okay, I think we have addressed almost all the chats. Okay, now physical findings. Should be scared for every sore throat? No. Now, rheumatic fever is common in school children, younger people. Younger people coming with sore throat and fever, especially school children with other backgrounds, you need not suspect rheumatic fever, but see whether that sore throat is due to throat infection, is due to organism, bacterial or viral. But if there is throat infection, streptococcal throat infection in a child of this age group, you should treat it with antibiotic. That is a primary prevention. Then you should watch for development of symptoms in the next 2 weeks. Then only you can consider it as probably rheumatic. Out of 100 children developing sore throat due to streptococcal infection with a specific organism, that is group A beta hemolytic streptococcus, only 2 to 3% will develop rheumatic fever. That is, out of the 100 school children group develop group A beta hemolytic streptococcal infection of the throat, only 2 to 3 will develop rheumatic fever because it's an immunological phenomenon. Post palpitation diuresis, okay, and this is classically described in supraventricular tachycardia. You need not bother about the mechanism. Okay, findings.
On examination, she's conscious, oriented to time, place, person, well built and nourished, dyspneic at rest, afebrile, height and weight could not be assessed.
Now there's something which I usually tell. Usually presentation should not be monotonous. Suppose a patient comes with a headache, fever. You say the patient is having altered sensorium, all those things. When a patient is coming with dyspnea, you have to say that the patient is comfortable at rest. She is not dyspneic. She is not orthopneic. She is conscious, oriented in time and place. I prefer that. The monotonous presentation has to be changed a little bit based on the situation. Okay, your examination also. When a person comes with the edema legs and breathlessness, you start examining the cardiovascular system. Where an alcoholic comes with edema and abdominal distension, you may go for ascites, cirrhosis, that system. Like that, this presentation, I may present like this. On examination, she is a middle-aged lady who is not dyspneic at rest. She is not orthopneic. She is comfortable in supine and sitting position. She is conscious, well-oriented in time and place. Okay.
Okay.
Because here dyspneic at rest is the most important thing. Now there you have to say dyspneic at rest, is she orthopneic? Is she propped up? Is she lying flat? You have to tell that.
Okay.
Dyspneic at rest you means what was the posture? Was she propped up or was she supine or was she sitting up throughout?
She was propped up, sir.
She was propped up. Okay, fine. That is important.
Okay.
That means she is still symptomatic.
Yes, sir.
She is severely symptomatic even now. Okay.
Bilateral pitting pedal edema was present. No pallor, icterus, cyanosis, clubbing, lymphadenopathy. No signs of infective endocarditis such as splinter hemorrhages, mucosal petechiae, JNV lesions, Osler's nodes, rod spots. No features
Now
suggestive
there
of...
again I have some differences. Are you suspecting endocarditis in this case?
No, sir.
No. But you are dealing with rheumatic fever. So why don't you talk about rheumatic fever negative points? That is the joints are normal. Okay. Sir, you can say that at the end of this, you can say, okay, fine. Sir, there are no manifestations of acute rheumatic fever like joint symptoms of cutaneous nodules and no evidences of no cutaneous manifestations of infected endocarditis because we are not entertaining that. That you can put it. Okay.
No
so
arthritis.
Erythema of cutaneous nodule should have come above endocarditis.
Okay.
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 No markers of congenital disease. You are in problem. Okay. What are the markers of congenital heart disease? It's not relevant here. That's a problem. You invited problem. I always say that you give us questions. What are the markers of congenital heart disease?
Patient might have other features like flat occiput, depressed nasal bridge as in Down syndrome, remote possibilities, or like other syndromes like Halteram syndrome where patient might have associated ASD.
Okay, fine. So now you are giving us a chance to explore your knowledge in congenital heart disease. Okay, that's a problem. You are answering fairly well, but it should be avoided at that level because we are not dealing with congenital heart disease. If you are dealing with congenital heart disease, rather than telling that no markers of congenital disease, markers mean so many things. So there are no skeletal deformities, or sometimes we call it as syndromic features, which include so many things. But that will come to congenital heart disease only. Why did you say peripheral signs of aortic regurgitation? No, I don't know about your training. The features of aortic regurgitation comes when we talk about the pulse, all those things. We say there are no peripheral signs of AR, not in the general examination. Okay, in
Okay.
general exam, you talk to your teachers also, whether it should be presented now or later. Okay, because
Okay.
we have 4 examiners, 5 characters. Okay, 5 approaches. So you ask with your teachers, is this the way, whether it is needed or whether it should be modified? Next slide. Next slide.
Coming to the vitals, pulse rate was 64 beats per minute.
Don't say coming and going. Okay. No, no, don't say coming, coming, coming. Okay, just avoid that. Sir, cardiovascular system, vitals. Okay, pulse.
Vitals, pulse rate was 64 beats per minute. It was regular. The volume was normal. The character was normal. All peripheral pulses were felt equally on both sides. There was no apex pulse deficit. There was no radiofemoral or radioradial relay. Condition of the vessel wall was thickened. Blood pressure was 94 by 64 millimeter of mercury in the right upper limb in sitting position. Blood pressure was 94 by 70 millimeter mercury in the left upper limb in sitting position, and it was 106 by 76 millimeter mercury in the right lower limb in supine position. The respiratory rate was 28.
Okay, there are certain problems here. How did you record the blood pressure in the lower limb?
Sir, like since we didn't have a bigger 16 size cuff, the normal cuff I just tied in the calf region and checked through the dorsalis pedis, sir.
You auscultated?
And NIBP cuff also, sir.
NIBP cuff, you automatic.
Yeah, sir.
It is an automatic recording. Okay, fine.
Yes.
You should say that it is automatic.
Like
Okay.
with this
Okay,
one,
fine.
I was able to get only the systolic BP.
Yeah, that's it. If you have done manually, you need only systolic. So you should be very careful because in the examination, all NIBP will not be given. I don't know.
Okay.
You may present like this because always, even without recording, people are putting the blood pressure values. Okay, should be careful. If you are doing it, say, sir, in the sitting and supine, it should be in the same position. That is a problem. It should be in the same position. Why did you put the record the upper limb in sitting position and lower limb in supine position? These are certain areas where you are screwed. I will not. But they will ask, why do you put one in sitting position? You can't compare. Comparison is in the same position. Respiratory rate 28 per minute. Is it regular, abdominothoracic, thoracoabdominal?
Thoracoabdominal regular, sir.
Thoracoabdominal. Why it is thoracoabdominal? Because of the ascites? Okay. Be careful. Don't try to answer straight away to the questions which you are not familiar. Okay. We straight away answer without thinking. We know that we have not looked into that. That was thoracoabdominal or abdominothoracic. Am I right? You might have not looked into that. If you have examined, you would have put it straight away. So don't tell the answer in all questions. Be careful. Okay. Okay. 98.6 measured in axilla. So that means it is on the higher side. Okay. Your thermometer is digital? No.
Digital, sir.
Digital in axilla. Okay. I want opinion from the teachers also. Okay. I am not familiar with these things. Okay. Next slide. What I am telling you is you should be careful. Each point, not the accuracy. The method is important. Jugular venous pressure. Yes.
Jugular venous pressure was 9 centimeter of water measured from the sternal angle, examined in 45 degrees.
9 centimeters of water. 9 centimeters of water. Why did you mention this water? Okay. So when you are measuring in manometer, you say whether it is mercury or water, or what is the fluid you are using. Why did you use water here? Okay. Don't get depressed. I am trying to help you so that you can perform better in the examination. That was an unnecessary statement. You say 9 centimeters of blood column is fine because you are looking at the blood column only, not water. Because the density of blood is different from that of water. Okay. So that could have been avoided. So jugular venous pressure is elevated 9 centimeters from the sternal angle in 45-degree position. Normal A wave, prominent B wave, rapid Y descent, which is a very, very difficult thing. Okay. JVP is extremely difficult even for the examiner, but fine. What are the conclusions you have drawn from that? Now we are getting enough questions from the audience. but we don't get a chance to ask questions to them. Am I right? Then you would have been happy. If you had asked a question, you get a chance to ask questions to them. Okay, what are the information you have got so far? Our diagnosis is not based on auscultation. You know that? We'll prove that. Okay? Because auscultation is the most difficult thing. Okay. What are the information you have got so far from examination? General examination, dyspneic, propped up,
She's propped up, but still she's dyspneic. JVP is elevated.
So what does it indicate? What does
Right
it
heart
indicate?
failure. Cardiac failure. Right heart failure.
Congestive heart failure. Right heart failure. Congestive heart failure.
Yes.
From the pulse and the JVP, did you get any information about the rhythm?
Rhythm, it is regular currently, sir.
What is
because
the rhythm?
A waves are not.
What is the rhythm?
Currently, she's in sinus rhythm, sir.
Yeah, is it sinus rhythm?
Yes.
Normal sinus rhythm, because rate is normal, regular, JVP showing A wave. So she is in sinus rhythm. Then what is the JVP showing?
It is showing a prominent V wave and rapid Y descent. And
what does it indicate?
Probably like
No,
secondary.
means you have to have differential diagnosis.
No,
probably.
sir. She's having tricuspid regurgitation also.
You have a differential diagnosis? What are the causes of prominent V wave in the neck? That is, V wave is a systolic phenomenon. So in systole, the pressure is rising in the right atrium. So some chamber pressure is transmitted. Which are the pressures? Systolic pressures, higher chambers containing higher systolic pressure. It is
due to tricuspid regurgitation, or it can be due to an ASD. Atrial septal
ASD is a low pressure system. V wave means there is a prominent systolic wave coming to the right atrium. It could be from right ventricle. High pressure system is in the left ventricle. Third is the aorta. Okay, so you can have tricuspid regurgitation. Can you have the LV pressure? This is a DM question for admission for DM. The LV pressure to be transmitted to RA, any congenital heart disease. The answer is there. LV pressure to RA. That is the LV RA shunt. There is an entity called LV to RA. That is what DM admission, not for MD exam.
Okay.
Then suppose there is mitral regurgitation with ASD. The mitral regurgitation jet will go to the left atrium through the ASD to the right atrium to the jugular vein. ASD with MR. Then a few more things, you don't bother about that. Okay. The aorta can forget about it. But TR. Then ASD with MR. LV to RA shunt.
Okay.
Here for MD pass. ASD with MR for MD distinction.
Okay.
LV to RA shunt for DM admission. Don't say LV to RA as the first thing. Okay. Then what else? What is the negative diagnosis you have made from that? V wave prominent with rapid Y descent. Does it exclude anything? Rapid Y descent means the right atrial pressure is dropping down fast. That means it is emptying fast to the right ventricle. Okay, for that the tricuspid valve should open fully. Suppose the Y descent is low. That means the RA is emptying to RV slowly. The tricuspid valve is not opening well. Tricuspid stenosis. So a sharp Y descent excludes tricuspid stenosis. That also is for maybe MD distinction. Okay. Next slide. So we have found that she is in congestive heart failure. She is in sinus rhythm. She has severe TR. Next slide. Okay.
On inspection, shape of the precordium is normal. Apical impulse was not visualized. Left parasternal pulsations were seen. There was no epigastric, suprasternal, or supraclavicular pulsations. There were no scars over the precordium. On palpation, apex beat was localized to left fifth intercostal space, 1 centimeter medial to left midclavicular line. It was tapping in nature and there was no apical thrill. Left parasternal heave was present and it was systolic. The palpable second sound was there in the pulmonary area. Epigastric pulsations were palpable. There was no precordial or carotid thrill. There was no supraclavicular, suprasternal pulsations. On percussion, left heart border corresponds to the apex and right heart border corresponds to the right sternal margin.
Finish. Now we have to make the diagnosis. What are the conclusions now? What are the conclusions?
So like from the vitals and the inspection part, we found out that the patient is having congestive cardiac failure with severe TR.
Okay, that's fine. From the inspection palpation.
Inspection and palpation, left parasternal pulsation.
No. First question is there cardiomegaly? Is there cardiomegaly?
Yes, sir.
Hey,
No, like hypertrophy is there. Pressure overload is there, sir.
No, don't go for complicated things. Apex is medial to the midclavicular line, so there is no obvious cardiomegaly. Okay, then what does it indicate? Tapping apex beat. What is the condition where you get tapping apex beat?
Mitral stenosis, sir.
What is why the apex is tapping in mitral stenosis?
It's a palpable first heart sound, sir.
Maybe that may be the answer which you want. Okay, no thrill. Fine, that doesn't convey anything. If thrill is there, it is useful. What is left parasternal heave? Systolic. Now, I think, is there any diastolic parasternal heave? So there is no need to say systolic.
Okay.
There is a left parasternal heave. What does it indicate?
Right ventricular pressures are elevated, sir.
Right ventricular hypertrophy. Right ventricular hypertrophy. Okay. Now, epigastric pulsation is present. What does it indicate?
Can be due to tricuspid regurgitation or
maybe due to so many things. What does it indicate?
Elevated right ventricular pressure, sir.
Right ventricular hypertrophy.
Okay.
The two findings of right ventricular hypertrophy are epigastric pulsation and parasternal heave. Okay. Palpable second sound. What does it indicate?
Pulmonary arterial hypertension.
It need not be. A loud second sound, which could be due to PAH commonly, but a dilated pulmonary artery per se can also in thin chest individuals. Okay, you are fine. Now, what are the causes of left parasternal heave other than RVH? You kept the hand here, you are get pulsation. What are the possibilities? RVH agreed. So it is a dynamic thing. Okay, so something is expanding, pushing the sternum. One is right ventricle. You go for the structures posteriorly. Any structure which is behind can produce parasternal pulsation. What is the posteriormost chamber in the heart? There are only 4 chambers. Left atrium. Can the left atrium expand in systole in any condition? Severe mitral regurgitation.
Okay.
In severe mitral regurgitation, the left ventricle empties the large volume under high pressure, the LA expands and can push the right ventricle anteriorly. What is behind left atrium? Which is going down to the aorta, abdomen, aorta. If there is a very prominent aortic aneurysm, that also can push the left atrium heart anteriorly. So parasternal heave is due to right ventricular hypertrophy commonly. Less commonly, the left atrial expansion of mitral regurgitation, and an aortic aneurysm can also. Okay. Then how to differentiate between parasternal heave? We are dealing with a valvular heart disease. Yes. Parasternal heave of right ventricular hypertrophy versus left atrial expansion. Okay, you may not. Now, next is epigastric pulsation. What are the causes of epigastric pulsation? One, from above, right ventricle. From behind, it could be aorta.
Aortic aneurysms.
Aortic aneurysms. So that will be felt in the palm of the fingers. Okay. And the RV epigastric pulsation will be felt in the tip of the fingers. During inspiration, what happens? The diaphragm comes down, the RV lift becomes more strong. With inspiration, the abdominal wall moves forwards so that the aortic pulsation becomes weak. You keep the hand like this. From above, it is RV, which augments during inspiration. Whereas when it is due to aortic pulsation, when the abdomen distance, the hand moves forward so that the impulse will become less. The third thing which the examiner wants is hepatic pulsation. If the liver is enlarged,
Right side.
yeah, then I think it will be diffuse over the hypochondrium, not localized. So epigastric pulsation or a parasternal heave with epigastric pulsation, it is RVH.
Okay.
Okay.
Okay, sir.
Now, parasternal left atrial expansion, they will ask you if you want to get 75% marks. Left atrial expansion is a little up and a little lateral and a little late systolic, learned by heart.
Okay.
Left atrial expansion is a little up, a little lateral, and later in systolic. Okay. Other, you need not recollect those things. Even if you forget that, you will get good marks.
Okay.
So what is your inference from this thing? This patient has definitely features of
Right ventricular hypertrophy
diagnosis.
and
Palpable second sound. So what is the diagnosis we can offer?
pulmonary hypertension.
Arterial or venous?
Pulmonary arterial hypertension.
So pulmonary hypertension. Okay. So
Okay.
we have found that this patient has pulmonary hypertension, tricuspid regurgitation, congestive heart failure, sinusedem, NYHA4. Status post-commercial. Okay. Now, obviously, this is a valvular heart disease. Which are the valvular lesions you know of?
Mitral stenosis, mitral
Yes.
regurgitation,
Then.
aortic stenosis, aortic regurgitation.
Now, what
Tricuspid.
Okay, tricuspid we have already diagnosed. Okay, how will you exclude these things to arrive at the diagnosis? Is it aortic stenosis? Which has produced heart failure?
But pulse character we told us normal. If it was a
Symptoms
severe
of aortic stenosis, angina, syncope is not there.
symptom wise is
Pulse,
not there.
Pulse is normal volume. What is the pulse in aortic stenosis?
Low volume pulse can be slow rising and late peaking, like pulses, powers, retardus and all. That
Which
is not
important. Low volume, slow rising, which is important?
low volume.
No, slow rising. Low volume can occur in so many conditions. Slow rising. Okay, then what else? Aortic stenosis. Apex in aortic stenosis.
It is a pressure overload, so it will be
Nothing, no explanation. Apex in aortic stenosis.
heaving.
Why don't you answer that? Heaving. So is it aortic stenosis?
No, sir. No, sir.
No. Is it AR? Aortic regurgitation?
AR again, like coming from the history, like such a chronic issue.
Don't forget about it. Come to the solid thing. AR can present in any way. It may be an association. Why do you say it is not AR based on the physical findings?
Pulse volume is not coming to like high volume or collapsing pulse. Other
Pulse
peripheral
volume is normal, which is the most important thing in the
sign.
pulse and blood pressure. Wide pulse pressure with low diastolic pressure. AR is a diastolic phenomenon. When the blood leaks from the aorta to LV, the diastolic pressure comes down. That is the basis for all peripheral signs. So the moment you find that the pulse pressure is normal, no question of peripheral signs of AR. Okay. Then what about the apex?
Apex will be hyperdynamic in case of aortic regurgitation.
Displaced down and out, and character will be
hyperdynamic.
Forcible or high. So AR in or out?
It's out of our list.
What we are talking is significant AR, which is producing this heart failure. Mild AR may be seen, but that's not a basic lesion. Okay. Now comes mitral stenosis or regurgitation.
Mitral regurgitation, again, pulse rate can be hyperdynamic, which is not seen here.
There is no. How will you differentiate? Apex. What is the apex in mitral stenosis?
Hyperdynamic.
Mitral stenosis.
Oh, no, mitral stenosis is tapping, sir. Mitral regurgitation, hyper.
Apex displaced or not in mitral stenosis?
No, sir. Position is
Usually not, unless they go in for advanced stages. Character?
tapping in nature, sir.
Tapping. MR?
MR hyperdynamic apex, which is pushed down and out, sir.
Okay. So what is the diagnosis?
Mitral stenosis, sir.
Restenosis or original stenosis?
Sir?
Restenosis or simple stenosis?
Restenosis, sir.
So rheumatic heart disease, status post mitral commissurotomy 6 years back, now has features of restenosis, pulmonary venous hypertension, pulmonary arterial hypertension, tricuspid regurgitation, congestive heart failure, sinus rhythm, NYHA4. Okay?
Yes, sir.
Is it clear?
Sorry
Is
to
it
interrupt,
mild,
sir.
moderate?
Sir, we can have 10 more minutes, sir. So sorry to interrupt, sir. Sir, 10 minutes could, sir.
Okay, fine.
Oh, sure.
So,
sorry to interrupt, sir. Yes.
no problem. So now the 10 minutes. Now, what is the severity of mitral stenosis? Severity of mitral stenosis.
It is a severe MS, sir, because there is a transmission of elevated left atrial pressure and there are features of
Any
pulmonary.
patient, nothing, simple. Any patient with heart disease, symptomatic, more than class 2. Any patient with mitral stenosis or any lesion who has gone in for heart failure, any heart disease which has produced PAH has to be severe.
Severe.
Auscultation, how will you assess the severity of mitral stenosis?
The S2OS gap is inverse.
Most difficult. Have you ever heard opening snap? Very difficult. Can you say it is 60 milliseconds or 80 milliseconds? No. So it is extremely difficult. Okay. But we anticipate the findings. Auscultative findings quick.
Coming to auscultation of mitral area, S1 is loud, S2 is heard. There are no S3, S4 or clicks. There is a sharp early diastolic sound suggestive of an opening snap. There's a mid-diastolic murmur, which is rough rumbling, best heard in the mitral area. It is low-pitched, grade 3, best heard with the bell of the stethoscope with patient in left lateral position. Better heard during expiration with a presystolic accentuation. There is also a mid-systolic murmur, which is...
Okay, forget about that. Wait. This should come. That the thing is, there is a grade 3/4. Diastolic murmurs are usually not graded, but it can be graded as 3/4. Systolic murmurs up to 6. Sir, there is a grade 3 low pitch, rough rumbling mid-diastolic murmur. Where is mid-diastolic murmur with presystolic accentuation? That should come there. Third best in the mitral area in left lateral position with all the other things. Mid-systolic murmur, rough, medium pitch, best heard in the aortic area. Grade 3. Short crescendo, decrescendo. Okay, fine. Somebody might have helped you to present like this because it is extremely difficult for even for us to bring these things. Okay. Next thing, that's all. Other systems normal. Okay, fine. Same thing, 2 murmurs, fine. Okay. Second sound, loud, narrow split, A2, P2. There again, problem comes because narrow split is not defined. If you have heard the split, it is a normal split.
Okay.
Or a wide split. So you can have second sound at your level, probably at my level also. Either it can be split, either it can be normal split or a wide split. Wide split, fixed or moving. A narrow split is extremely difficult. I don't know, with your examiners, teachers, we have to ask what is the definition of narrow split. Some examiners may ask that, you note down. Discuss with your teachers and examiners whether I can use the term narrow split.
Okay.
Okay. What is the definition when I will say narrow split? I may not be very adamant, but I will not use this narrow split. Okay, fine. Other systems normal.
Other systems, respiratory system.
Fine. Go ahead because we are running short of time. Okay. So, auscultation, what is the additional information you have got?
Auscultation, Systolic murmur in the tricuspid. Sir, one more thing, like we
Okay.
had seen only the TR and MS murmur, but patient had a mid-systolic murmur in the aortic
Forget about
area.
that. That's a very innocent thing. Now, from the auscultation, what is the additional finding regarding microstenosis you have got?
It is a pliable
Very
valve.
good. It's a
Because
pliable
opening
valve because you have found the first sound
opening.
is loud and you heard an opening snap. It is a pliable valve. Okay, chronic rheumatic valvular heart disease, microstenosis, status post PTMC 6 years back, now has restenosis severe, mild AS, I don't know. Then comes pulmonary hypertension. You should put that sequence. Microstenosis severe, pulmonary arterial hypertension, venous hypertension, pulmonary arterial hypertension, tricuspid regurgitation, congestive heart failure, sinus-rhythm, congestive heart failure, sinus-rhythm, NYHA class 4. No signs of active rheumatic fever or endocarditis.
Okay.
I think, is it okay? If you have any doubts, you can ask. Because taking ECG and X-ray, it will take a long time because I have to teach you because you're not familiar. At the most, I will, if you have time, after taking this chat, we'll take Gerbody VSD. Okay, that is LV shunt is Gerbody VSD for DM. HOCM, I don't know what that question comes at this level because we'll take questions related to this only. Why systolic blood pressure is low, normal volume pulse, contradictory. What is the blood pressure?
– 94/64 millimeter of mercury.
94 by
64. 64 millimeter of mercury, sir.
Okay. Can you answer that? Why normal volume pulse? That is a question. Systolic BP is low. Why normal volume pulse? Yes, pulse volume is determined by the pulse pressure. Here the pulse pressure is 30, which is normal. That could be. Second thing, our findings need not be right always. Okay. Mitral facies is an extremely rare phenomenon. Flap, I don't know why that question of flap comes only when you are talking about some problems, complications. Post this thing, we discussed post-palpitation diuresis, we discussed. Mitral facies is very rare in fair skin individuals. I have seen only 1 or 2 cases during my early period of training. Flap, I don't know the relevance in this case. BP is low, normal volume pulse, we have discussed, tried to explain. But more important is we can, the findings may not be absolutely right. Somebody has to check that. HOCM may not be relevant in this case. Gerbody VSD is left ventricular to right atrial shunt. LVRA shunt is Gerbody VSD. Burn heme effects. This is not, the spelling is not right. Burn heme effect. Burn heme effect is, this is classically described in aortic stenosis severe, where the hypertrophied septum will bulge to the right ventricular cavity. That is the hypertrophied interventricular septum in severe LVH. That hypertrophied septum will bulge to the right ventricular cavity, reducing the RV cavity size, resulting in elevation of the JVP and a prominent AV. This is again DM because this question was asked today for the DM exam. That is burn-in effect. Then patient had irregular palpitation on beta blockers. Should a diagnosis of, now we need not say diagnosis of treated AF because we need not make a diagnosis based on a history on palpitation. If mitral valve disease develops atrial fibrillation, it will not be reverted to normal with beta blockers, especially when the patient has gone in for heart failure. So it could have been paroxysmal AF at the beginning, but later when irregular palpitation may not be right. Okay, but we'll check with the electrocardiogram whether her finding is right or wrong. On beta block, in a patient with mitral valve disease, AF is, once they develop, is likely to be permanent, especially if it has advanced to congestive heart failure. So that irregular palpitation we have to clarify again. History taking is very important. You have the ECG with you?
No, sir.
You have the ECG? No, fine.
No, sir.
Doesn't matter. Fine. Any questions from your side? Any doubts?
Sir, actually one thing if pH per se can cause this tricuspid regurgitation, no, sir. So regarding that, how do we say the interval, sir, like that A2, P2 and all?
No, A2,
Because in
P2,
one that will be like wide split, another one
A2, pardon?
because in one it can be narrow split and in another one it
No,
can
no,
be
no.
wide.
It is not like that. Second sound, JVP, second sound. You should try to get away from that because most difficult areas. Second sound is most difficult oscillator to find. Our thing is you examine and see whether second sound is single, normal, wide split. If wide split fixed or not. Reverse split you cannot pick up. That is very clear. If you say reverse split, you have got the tip. There is no doubt about that. Because we also find it difficult to pick up reverse split. Then you have to say whether it is normal. That is the first thing. Your commitment of the finding. Is it normal split, wide split, wide fixed split, single? What is it? That is the first thing. Then we'll ask you what are the factors which can influence the split in this case. It's a broad area. It's a difficult area also. I think we don't have time to discuss. Already it is 10 minutes. I think who is the...
Yes, sir.
Shall we stop at this point?
Oh, yes, sir. So we'll go. I think it's time, sir.
Yeah, fine.
Oh, sir, thank you very much, sir, for that.
Thank you very much.
Yes,
Thank
sir.
you.
For that amazing
Thank
discussion.
you
Thank you very
for
much,
giving
sir.
me the opportunity to
Yes, sir.
interact with my dear students
Yes.
again in AMRITA, especially in presence of Pillai sir. Okay, thank you. Thank you very much.
Thank you.
Thank
Good
you.
night. Good night.
Thank you
Thank
very
you.
much, sir. Thank you, sir. Thank you, sir. In spite of all the COVID to come and join us, sir.
Yes, COVID is nothing. Our student is having COVID. Then
Yes, sir.
as a teacher, I have to be more active.
Yes, sir.
Okay. So she is doing extremely well. Performance academically, she is good. She has done extremely well.
Thank you.
And answering the question, she has done beyond my expectation. Keep it up.
Yes.
Thank you.
Okay.
Thank you, sir.
Okay.
Thank you.
Thank you.
Thank you, sir.